Hello, everyone. Today we're with Carrie Addison, Project Evaluator with Family Health Centers. So Carrie, why don't you start by telling us a little bit about yourself and what you do at Family Health Centers.
Okay. I'm the project evaluator here for our two SAMHSA supportive services and housing grants, so our two Housing First projects. As a SAMHSA grantee, we are required to collect evaluation data from all of our participants in housing. We have a standardized government survey called the Government Performance Results Act, or GPRA interview. So I administer that to our clients at intake and every 6 months thereafter. We meet for a person-to-person interview. I ask them a number of questions about different behaviors and different aspects of their lives. We talk about their substance use, their mental health, education, income and employment, risk factors such as sexual behavior. As you can imagine, some of these questions are very personal. And sometimes clients are uncomfortable answering them or may not even want to provide honest answers. So it's really important as part of this job is to be able to build rapport and trust with the client so that I'm just able to get the most accurate and honest data moving through the project so I can track it as effectively as possible. Of course, the data that's used is reported to our government project officer and our oversight committee on a biannual basis. A big part of my job is analyzing the data and being able to interpret it and communicate it in a way that other people can understand it and in a way that we can look at our own project and what we're doing well and what we can improve. Beyond the requirements from our grant, we try to evaluate our program from a number of different angles. I do process evaluations throughout the grant to make sure we're implementing the program as we had said we would and following the Housing First model that we proposed. Consumer feedback is very important to us. We do focus groups, customer satisfaction surveys as well, and try to use that to inform our practice as well. And then administrative data is also important. I've worked with different organizations and agencies in the community to gather data on outcomes such as incarceration or emergency room use to see how those change for our clients as well.
So you're measuring outcomes for folks that were homeless and have now moved into permanent housing. What are some of the most significant outcomes that you've seen? I think you've been measuring, the program's been measuring data for 5 years now. So can you share with the class just some of the outcomes you've been measuring and what you've seen as far as progress in the clients?
Of course. Well, number one, our goal is to take people off the streets and keep them permanently housed. So our number one outcome has been housing retention. We have several folks that have actually been housed for the entire 5 years of our grant, many more that are graduating from the program and will live independently in subsidized housing without the assistance of a case manager or supportive services. And then, of course, we are substance abuse and mental health services grantees, so those are some strong focuses of our program. We follow a harm reduction approach, and I've found that the outcomes reflect that considerably. For example, the number of participants that report using alcohol really hasn't changed very much throughout the life of the project. But when you look deeper at factors such as the average number of days of alcohol use or days of binge use, the use of more severe drugs like crack cocaine, those factors we have seen more substantial decreases in definitely use. The same has been true for mental health as well. With the GPRA interview, we ask questions about how individuals are affected by depression, anxiety, impaired brain function. And of course, those are, for someone with a chronic mental illness, those things don't go away, and the data reflects that people still experience those symptoms. But when you look at the actual severity, the number of days that people report being bothered by those symptoms, and the severity that they're bothered of them, it is those things that have decreased over time. We've also seen people report less arrest, spending less time in jail, less visits to the emergency room, less inpatient hospitalization, and then a number of folks have gained income as well through the life of our project. So either through working or obtaining disability benefits, they've been able to achieve a stable income as well.
Carrie, are there areas where through focus groups or patient surveys that you found things that weren't working well and needed to improve, and how was that accomplished or communicated with staff?
Yes, for example, one good thing was, of course, here at Phoenix we are a homeless clinic, meaning that we serve homeless individuals. That's what our funding mandates. And as part of this project, we put individuals in housing, so in essence, they are no longer homeless. And with that came a requirement for people to find another medical provider. Through focus groups and surveys, we started to find that this was really, could be an upsetting or even traumatic aspect of the program for our clients. They have doctors and therapists and nurses here that they've built rapport with over the years. The Phoenix Clinic understands the needs of homeless people better than other providers. And our clients are really attached to that, so we wanted to be able to give them the option to keep seeing us. And apparently this is a national trend as well, because Healthcare for the Homeless has recognized it as well. And together with their policy changes, we've been able to adjust the program to our clients are able to continue receiving medical care here. We've been able to allocate time for our nurse practitioner to actually visit clients in their home, to have a clinic offsite for people in housing so they can meet a provider there with their case manager and work on medical issues as well.
What are some of the challenges of doing outcomes measurement and program evaluation within a nonprofit organization?
Well, amount of time and resources is of course always an issue. I have over 100 clients to keep up with, so the day-to-day administrative task sometimes creates a difficulty in making time to pursue other evaluation efforts. Of course, a lot of the data that we rely on is self-reported, and as I discussed earlier, clients may not be comfortable, may not want to answer personal questions, or in the beginning when we first meet, they may be less likely to provide honest answers. And later on, they gain more comfort and become more honest, which is good to build the rapport. But on the other hand, it can skew our outcomes as well because they don't accurately reflect what is going on with the client. So that's why I mentioned rapport trust is a very big issue. And then, of course, I talked about administrative data as well. That has proven to be an extremely difficult task. There are agencies in the community that want to work with us, but everyone has their own privacy policies, confidentiality rules, HIPAA to follow. So getting through those barriers, linking with data people, finding compatible data to answer our questions has been a challenge as well.
And I know that this particular project uses a number of what are called evidence-based practices. Mm-hmm. For students that may not be familiar with that term, can you explain what the term evidence-based practice means?
Okay. Well, evidence-based practice is just that. It is a practice that has been used before, and rigorous research has been conducted to document its effectiveness. So like I said, one evidence-based practice that we've used here is Housing First, which was based on the Pathways to Housing program in New York City that began in the 90s. And SAMHSA studies and other research have documented that program to be successful in keeping people off the streets and reducing their use of substances and the severity of their mental illnesses as well. So we followed that model in our grant application. So we are obligated to follow that, and that's one reason I mentioned fidelity is important as well, and to conduct process evaluations to say that we're doing the practice just the way that we said that we were doing it. And then we've added other evidence-based practices along the way that we feel like are compatible. I mentioned harm reduction earlier, which means that some people are not ready for abstinence from drugs or alcohol, or may choose not to be, and that's okay. But we can look at ways to decrease the risk of their behavior. For example, getting drunk on the street and passing out and robbed or beaten up. Instead, looking at it, well, if you're going to drink, can you do that in a safe place? Can you limit your use? You know, what is the amount that causes problems? Are there certain people that you engage in this behavior with that tend to cause problems as well? And look at that. That also has been documented as an effective evidence-based practice, and we've carried that out as well.
Now, a lot of nonprofits aren't as lucky as Family Health Centers to have a grant that allows us to fund a full-time project evaluator. For agencies that don't have that luxury, what are some things that they what are some ways in which they can evaluate their projects that don't really cost any money? Do you have any thoughts?
Using staff and available resources that they have. Students are always a great resource as well. There are plenty of students out there looking to do research, needing to do projects for school, wanting internship experience. They usually have a set of skills that are particularly good for conducting evaluation efforts. Just exploring online, looking, SAMHSA offers a number of resources, and other government agencies as well. You can find tools that can be used often for little or no cost at all to evaluate with your clients as well. Time being the most resource, I think anybody can pursue some degree of evaluation no matter what their experience, but just having the time to be able to do that. And I will just add that the benefit of that is it gives your program so much power and advances their ability to go after other funds to promote their image in the community. For example, we received our first SAMHSA grant in 2008, which was a 5-year, $2 million grant. In 2011, SAMHSA introduced a new grant called a CABI grant, which was a 3-year, $1.5 million grant. And we were able to look at the successes of our program and how we could enhance the services that we offered through that to apply for this new grant. And that was a big part of the reason that we were funded for another project, is we were able to demonstrate the successes of our first project.
Kind of final question, the folks that are viewing this are students in my nonprofit management class many are currently working in the nonprofit sector, and others hope to work in the nonprofit sector in the future. So what advice would you have for them as folks working within the nonprofit arena?
For evaluation, think ahead. It's always easier to plan in the beginning what you want to look at. When you're implementing a program and doing flow charts and logic models, think about what outcomes you want from your project, just like anyone would do, and think ahead about ways that you can measure that. So you can, because it's definitely more difficult to go back and do that retrospectively as well. And to think about how can you use your data if you're collecting it. It's no good on the shelf. and being able just to communicate it effectively to the community. How would the average person in the community interpret this? And being able to put it in a language that they understand and they can see the value of your program will increase the support and popularity of your program as well.
Great, Carrie. Anything else you want to add?
Not that I can think of.
Okay, thanks a lot.
Thank you.